Good morning.
Hello.
Good morning, Dr. Manish.
Yeah, good morning, Pratibha. Good morning, Dr. Chandra.
Hi, Manish. Good morning.
Good
Happy
morning,
Sunday.
Dr. Roy. Thank you, sir, for joining on Sunday morning.
Thank you.
Are you taking the rest of the year off or going to be still seeing the patients tomorrow?
Yeah, we are still doing patients tomorrow. No specific plans for New Year.
We too are working tomorrow as well as half day on 31st, but are closed on 1st. Yeah.
All right. Good. So we have no travel plans also. We are largely staying in
Right.
city.
It does get a very chaotic traveling
Yeah.
this part of the
Yeah,
month end and year end.
that's right. I was recently in Rishikesh, AIMS.
Mhm.
Yesterday I was there. So that was a good outing.
Okay.
Work plus
Yeah.
leisure.
Yeah.
Okay. So other people are joining, I think. Yeah, Dr. Sarita, I can see. Good morning, Sarita.
Good morning, Dr. Sarita.
You're muted.
Good morning.
Yeah, that's good. So Dr.
Good
Sarita
morning,
is going
Dr.
to take us
Chandra.
forward. She's the moderator for today's program.
Yeah.
Good. It's nice to have the most articulate moderator.
Thank you so much. That is so nice of you.
A good moderator makes job for the panelists and the speakers very easy.
That's right.
So Pratibha, give us a cue when we are good to start. I think the first one is Dr. Viveka. We
Yeah.
don't see him online yet. So whenever can
I
everyone
will
is
let you
ready.
know
Yeah.
as soon as he joins.
Yeah.
See Dr. Sameer Dani, who is here. Hi,
Yes.
Sameer.
Good morning, Dr. Dani.
Hi, good morning.
Dr. Viveka is also here. Hi, Dr. Sameer. Good morning. Good morning to everybody.
Good
Good
morning.
morning, everybody. Hi, Dr. Sameer, Dr. Viveka.
Hi, Dr.
Good
Sarita.
morning, Dr. Viveka.
Yeah, good morning to all of you.
Morning.
And I think Dr. Sanjeev Roy has also joined.
In the interest of time, I think it's 11 and we are good to go, Dr. Manish.
So we get started, Dr. Sarita?
Yes, sure.
Yeah. So is the recording on, Pratibha?
Yes, it
Yeah.
is.
Great. So good morning, everyone. A very warm welcome to you on this in this cold Sunday morning of December for our very first session of optimizing PCI outcomes in AMI, which is part of our AV Cares. I'll very briefly talk about AV Cares. AV Cares is part of our Abbott Educational Network session, and in India we are going to have multiple sessions beginning today and going all the way up to next year as well, where the aim is to get the experts like you on the table and also have some of the upcoming intervention cardiologists and basically a shared learning through multiple cases as well as some didactics. We will cover multiple topics, as I said, throughout the uh, series, but today's topic is optimizing PC outcomes in AMI, and we have an expert panel comprising of Dr. Praveer Agarwal, Dr. Sanjeev Roy, Dr. Subhash Chandra, Dr. Viveka, Dr. Sameer Dani, and Dr. Arun Chopra. Each one of them is going to cover different aspects of treatment of AMI, and our moderator for today is known to everyone, Dr. Sarita Rao, who's a senior intervention cardiologist and director cath lab at Apollo Hospitals, Indore. She's also the president of WinCar Association, co-chair of EAPCI, and board members of APSIC Win and CSI Pink Council, vice president of MPCSI, and an expert intervention cardiologist with the specialization in multiple complex procedures. She has an illustrious career, which includes doing multiple firsts, including the first female IVC in India to use an indigenous bioresorbable scaffold, first female intervention cardiologist to do live case with Impella at TCT Asia, and many other things. So she's going to be moderating the session today, and I'll hand it over to you without any further ado. Over to you, Dr. Sarita.
Thank you, Dr. Manish. And I would like to once again welcome everybody to the AV Cares program today. And today our topic is optimizing PCI outcomes in acute MI. Now, all of us here are very well aware that an acute MI situation is actually a Pandora's box. You really don't know what you're in for when you take a patient with an acute MI into the cath lab. And today we're going to look at all those aspects of it. So we're going to start off this program with evidence-based approach to ACS. Then we're going to talk about the treatment of acute MI, how the different considerations are there. We're also going to talk about bailout situations in an acute MI situation. Also, the different things about the thromboresistance, how do you treat these patients? What about if you come out in a scenario in which you have an anomalous artery over there, or you have a situation in which combined with the ACS, you have calcium over there. So it's basically a situation in which you have to be prepared for everything. And we have a host of very interesting and experienced faculty today who's going to guide us through this entire program. And without any further ado, let us go to our first speaker today. And Dr. Viveka Kumar is going to be speaking about evidence-based approach to ACS. Now, none of the experts here need any introduction, but I'll just say that Dr. Viveka has a host of experience, and he's principal director and chief of cath labs at Max Super Specialty Hospital, Saket. He doesn't need any further introduction. So over to you, Dr. Viveka.
Yeah, so thank
Thanks,
you.
Dr. Rao. Dr. Viveka, just a sec. So we'll try and make it very interactive. So please feel free to ask questions to the panelists. So we'll have first 10 minutes for the talk, followed by a couple of minutes for the Q&A. So please try and ask as many questions to each other, and our audience will make the most out of the interaction. Thanks, and over to you, Dr. Viveka.
Yeah, so thank you, Manish, and thank you, Dr. Sarita, for this introduction. And as you would know that there are a lot of evidence coming in, and so I've shared my slide. Hope it's visible. Manish, can you see the slide?
Yeah, we do see your slides, Dr. Viveka.
Perfect. So if you see the evidence-based approach to acute coronary syndrome. So like, we have been trying to optimize not only the stent, but how do we optimize, and we need to have data in that direction. So uh, we have been, not only the upgradation of the stent and better quality, thinner struts, all those things have been worked up in recent past. And the evidence has also shown, and that has, the reason why the revolution like Absorb went into relegation, because it did not show superiority. So similarly, we need to keep on improving the outcomes. And now, since the PCI has come to such an extent that it's very difficult to beat the current practices, but still, very interesting information has come off late. So. The reason why we focus more on acute coronary syndrome is that it's a major global morbidity and mortality. And if you look at the data, especially India-specific data, if you look the acute coronary syndrome and acute myocardial infarction, they are the big bane of the society, because at young age we get a lot of young myocardial infarctions and all. And then as an interventional cardiology perspective, especially in peripheral areas, the major chunk of intervention is the acute coronary syndrome intervention. So if you look at the reason why we need to focus on this, that this is something where the incidence of heart failure and all, if you don't treat in time, it becomes higher, and there is a reduced rate of survival also if you don't treat in time. And the older data suggested that almost 33% of people with acute myocardial infarction, they are not able to reach the center also. So we need to have more and more treating centers also. So if you look at the treatment algorithm to guide the uses of the uh, patients who have got acute coronary syndrome, this is something which is presented in European Heart Journal 2019 by Johnson et al. That treatment has to be, more channelized and evidence-based. So you should not be just doing on your whims and fancies. There has to be supported by good data. So if you look at the patient who have got acute coronary syndrome or suspected acute coronary syndrome, so we need to triage them to biomarkers, ECG changes, and risk factors. So if these things are positive, sometimes, we see that the patient had non-obstructive coronary disease. We need to do intracoronary imaging, because sometimes the plaque erosions and all would be there, and that can be managed on medication. But also the syndromes we are seeing quite often in patients who have got, SCAD, but that can also be seen only on, optic coherence tomography imaging. So how does the plaque behave? That is something which is very important. So not only for the diagnosing and triaging our patients. So once we take these patients who have got positive biomarkers, have got symptoms, and has the risk factors. So there will be three scenarios that when we do the angiogram, we find that the patient had normal coronaries, but still we need to rule out the things like Takasubo syndrome, Minoka, where the coronaries will be non-obstructive, even the drops are high, and then they SCAD. So these are the situations where the close observation and conservative management would be the treatment of choice. But if the patient had a plaque event, then we need to look at the intervention and PCI with stent, and then post-stent optimization would be the approach. So this is something where imaging would bring a lot of changes, and we'll just look at the data. And that too, in acute coronary syndrome, if you look at the imaging, the choice of imaging would be definitely the optic coherence tomography, because the diagnosis would be much easier picked up, and the pickup rate is much better. In the acute coronary syndrome, especially the plaque erosions, plaque ruptures, and all, they are much better seen here. So till now, we were just presuming that the imaging will make the intervention better, but now we have got very robust data, which was presented in, OQPC. PI trial, which was ESC Congress. It was presented last And that showed that when you do the OCT guided intervention compared to the angiography guided in complex lesion subset, that clearly showed that the OCT guided PCI significantly improved the clinical outcomes and enhances the safety and efficacy of coronary stenting. Also, the clinical impact on the clinical practice was also there, that this led to better optimization of the stent. So MSA and the edge dissection and other predictors of adverse outcomes were picked up and treated then and there. So the patients who have got, angiographic guided PCI, they were randomized 1-to-1 with the OCT guided PCI, and that this data showed that the primary endpoint, that was the composite of cardiac death, myocardial infarction, stent thrombosis, and ischemia-driven TLR, that was reduced by 38%. And secondary endpoints also showed that had met that the level of significance, that the patient had better outcomes in the spontaneous myocardial infarction. But of course, the contrast-induced nephropathy and other parameters did not change significantly. But this is a very, very good eye opener, that if we do our complex PCI, especially in acute myocardial infarction and the ACS, then definitely the outcomes with OCT guided PCI would be very good. So imaging is something which has become the will take your intervention to next level, and that is why the ESC guidelines have also inculcated it as a class 1 recommendation. So the class 1 recommendation that in this situation we need to do the PCI under the guidance of imaging, especially the either the OCT and all. If it is acute coronary syndrome, then also so the lesions like true bifurcation, left main, and the anatomically complex lesion and the long lesions, there the optimization and the PCI has to be done with the imaging. So we'll show a couple of cases also, that what are the things which we need to do. And practically also, it's not possible, and it's, a lot of people will say that it eats away a lot of time, but that's not true, because if you invest a couple of minutes more, the patient outcome is going to be much better. So this is a patient who was 73-year-old, presented with chest pain, heaviness, angina, and was a truly ACS. So this is something where hemodynamically he was stable. Angiography did show that the patient had a diffuse thin 100% occlusion of mid LAD, and that was left on medical management for many years, and that was also non-viable. So this time he presented with, had a previous stenting done, which was almost 5 years back, and that was done without imaging guidance. And he had right coronary artery stent was patent. So this is the lesion, and where the patient had, which led to acute coronary syndrome. So there, what we did is that we did a because the angulation and the strut protrusion, the catheter of the imaging catheter first did not go, so we had to, dilate it, and you can see there is a fairly good amount of calcium also there. So this after dilatation, we did the, we took a imaging run, and then we did a stent with Giants Sierra 3 into 28 at nominal blood pressure, nominal dilatation 12 atmospheres. And after that, we did a post dilatation on optimization. And then we took a run from left main to the distal circ, and then you can see. So the good point is that not only the stent opposition, the stent expansion, and the area, all those things would show. And this is where it showed that the left main was also okay, and the stent area was also. So this is the area where the in-stent neoplaque rupture was there, which was the cause of the acute coronary syndrome. So this, again, we did a post dilatation and optimized, because the stent expansion was not adequate on the imaging. So if you leave unexpanded stent, the adverse outcomes will be there. And then again, post optimization, is OCT run did show that it was absolutely fine, well expanded stents. And the so that could have been the reason why the previous, the patient had the acute coronary syndrome. So this was a large artery, and distal LAD was also getting filled through this. Another patient who was, nowadays, because of increasing age in our population, we are seeing more commonly, 83-year-old gentleman had hypertensive diabetic, presented with, again, ACS drops positive, had pulmonary edema. We settled him in 24 hours. Ejection fraction was 35% and had again hypokinesia of mid and anterior territory and was taken up for the angiogram. So you can see this is the angiogram was there and had a calcific lesion in the distal left main, also dominant circumflex, but he was very high risk for cabbage. And you can see that there was another lesion in the mid LAD, and so we decided that we'll have to evaluate the left main with imaging and do the culprit lesion looked like that the mid LAD lesion could be there. So we went ahead again. This was a severe calcific lesion, so we was pre-dilated to create some blood flow, and then did the and the calcium was very heavy, so we had to use high pressure open balloon to dilate. So after the lesion preparation, we did a stenting here. I think the pre-run for the OCT is missing, but after this we did an OCT run. I think this is not playing. So then the OCT did show that there was a significant lesion in the distal left main, also going into the circ. Circ being a dominant artery, we wanted to take care of the ostial of the circ also, so that the patient does not get a problem. So the imaging showed us that initially there was a very minor plaque in the ostial LAD. So we did a left main to circumflex stenting. We had already stented the mid LAD lesion. So left main to circ 3.5 28 millimeter stent was done, and then pot was done. After the pot, 4.5 into 8 millimeter balloon NC pot was done. So a lot of people, when they do image, left main intervention without imaging, they would stop at this thing that 4 millimeter balloon is good now, but we need to really look at the size, and it is very important that we should optimize pot with the adequate size balloon, 4.55 millimeters. So here we would have stopped with 4, but with imaging we had data, clear-cut information that we need to intervene with a bigger balloon. So then we did the ostium of the LAD was pinched. So again we did a culotte, and so LAD and the culotte was done, and again the rewiring and repot was done. And then after the kissing, this is the OCT images, which showed that the final outcome was good. So I think to conclude, I would say that the most important part of the acute Condy syndrome is the time is the essence of acute MI management, and precision PCI ensures better long-term success and outcomes. Across randomized control trial, the meta-analysis and observational studies of the cobalt chromium everolimus eluting stent is the device which has received the most extensive investigation ever when it comes to acute Condy syndrome. And evidence suggests that the Zines group of stent, and in our experience also significantly reduces the stent thrombosis, not only compared to the first generation test, but also the bioabsorbable polymer stents also. And in case of plaque erosion, OCT may allow us to leave it alone with thrombolytic and antithrombotic treatment without stenting. And if the minimal lumen area could be large enough and the flow could be maintained sufficiently. So in this situation, there are clear-cut data that, in non-obstructive or plaque erosion area, we can easily leave. But if we don't do the imaging, then probably we unnecessarily might have to resort to stenting in these areas. So on that note, I'll conclude, and over to the chairpersons. Thank you very much.
Thank you, Dr. Viveka. That was indeed a very interesting and a very lucid presentation, and beautiful cases you have illustrated. And we do agree with you that imaging has actually totally changed the scenario of PCI. And the uptake of imaging is also gradually increasing. In addition to that, it has changed the way that we were doing procedures, more amount of post-dilatation. We're looking at vessels differently. We typically upsize now. And also, you were very right when you said that the moment your lab gets tuned to doing imaging, it hardly takes 5 minutes more in the procedure. So I think imaging is totally changing the scenario. Now, you showed very interesting cases. So I'll just set the tone of the discussion. I repeat that everybody from the panel is free to ask questions and to interact. I would just like to ask you, that first case that you showed was very interesting, and you also had imaging on the table. So that ISR in the circumflex, did you at any time think of doing a cutting and following it with a drug-coated balloon at that time in that ISR? What would your opinion be about that?
I think drug balloon is something which is, which has really been has shown to do the good, and there is enough data to show that this is again a very good alternative compared to the, so in bigger vessels like in this 3.5, still the everolimus stent is outperforming the drug-eluting balloon. So had there been the smaller vessel, if I say less than 3 millimeter, then probably I would have gone for the drug balloon. But in both the situation, I think we have data to support the things. But in smaller vessel and where the length is very long, probably drug balloon would be far superior approach than the stent again. Yeah.
So that's a very interesting point, and especially in ISR situation where we already have a layer of stent over there, that sometimes is a situation which we would like to use it. Also, I just wanted you to make some comments because when you showed the ESC data and when you talked about SCAD, so what's your typical approach when you see a patient who comes in with an acute coronary syndrome and you do the angiogram and you see that there is a SCAD? So two questions is, one is, do you image? And the second is that, do you stent?
Yeah, so I think that's a very good question. So that is where, if you look at the algorithm in acute coronary syndrome, we need to go by this, and imaging would really, change the situation, because if you have had a SCAD, then obviously there is no, significant atherosclerosis, and it's a spontaneous coronary dissection where the medical management would be the name of the game. So diagnosing. So if you just go by the conventional approach, you might not be able to diagnose. It's an imaging diagnosis. So approach would be to avoid stent in this situation, because this is something which you find more typically in young women and where the atherosclerosis is not even set in. So in this situation, the best approach is to do the imaging, diagnose the SCAD, and leave it on medication. Similarly, with the non-obstructive patients who have got these, the plaque erosions and all, there also you can easily leave them on. So on medication, and it has shown that you do repeat imaging after 6 weeks to 3 months, this thing has completely healed up. So I think in these situations, the better thing is to avoid any stenting and leave them on medication, especially the younger set of patients.
So I agree that SCAD always does better on medical management, and it's a ticking time bomb there if we are going to intervene in that, and we don't have great results in that when we intervene. And I think one more question for discussion, just for the sake of discussion, is when you come in acute coronary situation and you have a high thrombus burden, what's your take on thrombosuction per se?
Yeah, so I think in acute coronary syndrome, if you see, we have got such a large, powerful molecules now. We have ticagrelor, the prasugrel, then antithrombotic and all. So the guidelines yet do not support the thrombosuction yet, but we have seen that, as you asked, that in large thrombus burden area, especially the arteries, if they are very large, in those situations, 3.5, even 4 millimeter, we have seen that in younger patients, we have resorted to thrombosuction and with good outcome. And the advantage is that many a times in the younger patients, we have also gone with the powered mechanical thrombosuction with motorized things. And there we have seen that many a times we just don't have to put stent, just remove the thrombus, put them on antiplatelet and infusion of GP2B, and you can escape stenting in those situations. So I would say that any artery which has got 3.5, 4 millimeter proximal segment, either right or LAD, in those situations, thrombosuction is something which is a savior. Though the randomized large data, because that will include the smaller side branches, the LAD circ, and all those lesions there, the thrombosuction as a routine practice may not be helpful, but in given cases of high thrombus burden, this will be the game changer, I would say.
So I think that's a very important message, Dr. Viveka, that treatment has always to be individualized, regardless of what the guidelines say. But in our clinical practice, you and I guess the rest of the panel over here, we've seen that when there's a very huge thrombus burden, large-sized arteries, thrombosuction has actually helped us out of the situation. So regardless of what guidelines say, I think clinical experience and a case-based decision and individualizing the treatment is very important. Any comments from the panel, please?
We do have a question, Dr. Sarita, also from one of our participants. In case there is no comment, we'll move to that question.
So I think we have a question. In the event of acute MI SCAD, you recommend use of imaging. Do you have any concerns regarding wiring through the dissection to deliver the imaging catheter? Any concerns regarding possible wiring into the false lumen? Dr. Viveka, would you like to comment on that?
So usually we don't see that kind of problem when you have this CAD, especially the because you can go into the branches, and also you need to be have the basic skill and the so once you have gone through the artery, the dissected segment also, you need to be making sure that you are going into, if it is the LED septal perforators, and also you need to be 100% sure that you are in the true lumen. And the many a times these are things where, unlike the balloon induced dissections or, device induced dissection, in scats wirings are not that difficult. So that is another difference between, atherosclerotic area dissection vis-a-vis the scat, where the atherosclerosis part is less. So I don't see any challenges in those the scat patients, though it's very uncommon entity, but it's a real entity.
So I think what in SCAD, there is always a technical challenge, because sometimes when you're wiring, you might go into the false area. But the thing is that if you have a doubt on table, whether this is a SCAD lesion or whether it's an atherosclerotic lesion, and you're trying to decide whether you want to stent or you don't want to stent, there is no way that you would be 100% sure without imaging. So yes, it's technically challenging, but imaging would give you the answer as to where you're sitting in that situation and help you to decide your future option of treatment. Any other comments or questions from the panel? So I think in the event that there are no questions, thank you, Dr. Viveka. We'll move to our next presentation, and that's by Dr. Subhash Chandra. He's going to be speaking about bailout tap in acute coronary syndrome. And Dr. Subhash Chandra is chairman and head of department at BLK Super Speciality Hospital, New Delhi. Over to you, Dr. Chandra.
Thank you, Dr. Sarita. So let me welcome my colleagues on this platform at the outset on a cold Sunday. So after Dr. Viveka's extensive talk introducing how the ACS PCI should be done, I will dwell upon a situation where one could be in problem, especially dealing with bifurcations of acute coronary syndromes, that how do we bail out and what are the best technique in that moment. So I hope my slides are visible.
Yes, they're visible.
All right.
But could you go to slideshow? Yeah.
Yeah. So we have little evidence as far as bifurcation PCIs are concerned in STEMI. There are barely sub-studies drawn out from DK Crush 2, which showed that both stenting strategies which are compared there in STEMI situations had almost similar midterm and immediate clinical outcome. On the other extreme, there's a Corbis 2 registry from Korea that shows that comparison of two-stent strategy versus provisional approach, there's a significantly higher MACE in two-stent strategy, and the strategies followed there were largely DK crush and the complex ones. And the differences are largely because of the complexity of these lesions. The final kissing balloon was not possible in most of, in a few situations. Uh, Pot perhaps was not done in all of them in those days. And the time from symptom onset in PCI and the kind of antiplatelets used, all of them were the variables which led to this difference. I could only step upon a trial which was about comparing upfront two-stent strategy in true bifurcations in a STEMI situation. And it was seen that upfront two-stent strategy is feasible and safe for true bifurcations with large and diseased side branch in ACS patients, and it's related to a relatively low incidence of MACE. With that, we also look at the definition criteria and various other criteria when it comes to dealing with bifurcations. And if it fits into true definition high risk, then one has to choose the two-stent strategy. So I'll quickly go to the case. This is an interesting case, a lady who had an angioplasty of osteoproximal LAD in 2012. And now in 15, she comes back with instant restenosis. And this was the time when absorb was being used right and left in situations, especially when there's a crossover, thinking that the stud gets absorbed and the mouth of circumflex is nice and widely open. So in 2015, this intervention was performed for an instant restenosis. And this was the result after predilation of a metallic stent and a crossover left main to LED 3.528 absorb was used at 16 atmosphere, as you see here. And this was clearly covering the mouth of circumflex artery and hoping that this will get absorbed in due course and we can re-access circumflex in case needed. So this was done. And as was the norm after the deployment to absorb, a post-dilatation with a 0.5 millimeter high size balloon was done all across. And the previous metallic stent was outside this absorb. A port was also performed in left main. And this was the final result in 2015, as you see here. Looks pretty pristine. Circ is nicely flowing. Now this lady comes back to us in 2021, a classical acute coronary syndrome. And this is the picture where unfortunately there's a extensive instant restenosis at the mouth of LAD in absorb. Hopefully by 6 years' time, absorb must have gone away. And she presented with ACS and some thrombotic lesion in left main. And we suggested her surgery, but the family was not ready. She was a young lady of 50, and luckily RCA was clean, so the option of PCI was again followed here. And this is a classic Medina 111 lesion, as you see here. So the plan was to secure and salvage the circumflex, which is a very precious artery here. A run with IVS was captured here, and which showed that absorb had virtually gone away, and there was only a metallic stent seen in this run from LAD to left main. So the struts were not there, absorb. Des struts were seen. And a two-stent strategy was planned here upfront because the circumflex was very, very crucial artery and had to be secured at the outset. However, there was a thrombus, so provisional stent also deterred here, was not followed. DK crush, mini crush, and other approaches were playing in our mind. And bifurcation angle also mandated that either a crush or culotte perhaps would be needed here. But in the event of crisis, we were ready to salvage it by tap, which is the whole theme of my talk. Ejection fraction was well preserved, so IABP was just kept standby. And the fact that RC was normal, we embarked upon doing the intervention here. So the initial attempts were made to wire the circumflex. But unfortunately, during this process, perhaps we're not approaching the true lumen of circumflex, we're going somewhere else. The circumflex got blocked off and patient started crashing in a classical acute coronary scenario. And nothing would help us here. So blood pressure was going down, huge ST elevation, and she had chest pain. The whole idea shifted from saving circumflex to salvaging the left main and LAD. And therefore, a quick dilatation was done. And a crossover stent from left main to LAD was put to salvage the situation, which really worked. She started feeling a little better. And now was the turn to salvage the circumflex. And we first did a port. And as we know, the port helps here not only approximate the proximal stent, but also to make a channel to cross into the side branch. And with that intent, different wires were tried, but eventually what helped us was the Gaia 1 wire, which could cross through the strut of left main to LAD, which was placed here. A tiny 1.515 balloon helped us get flow into the distal circumflex. And now the situation was largely in control. Even the mouth of circumflex was opened with a bigger balloon. But what we saw to our horror that soon there was block in flow in circumflex, which I presumed was perhaps because of a dissection or a hematoma. And there the IVS images helped to define that this was actually a hematoma by the side of the guide wire. And the next step was to squeeze this hematoma with a tiny balloon. So a balloon was passed here, and the hematoma was squeezed to make the passage clean and get flow into the distal circumflex. Having done that, the tap strategy was followed with the long stent taken at 338, placed at 14 atmosphere, and a kissing was also done at the bifurcation, followed by a report, which is the norm. And this was the final result which we got. And the lady is doing well until the last few months. This was one case, and if the time permits, I could show another case before I wind it up. This was a gentleman who 47 diabetic and had effort angina, TMD was positive, and underwent a bypass surgery. But unfortunately, within 3 months' time, the guy ended up with acute coronary syndrome. And to our horror, we saw that the Lima to LED graft, which was placed here, was not actually connecting to the distal LED, and it was going somewhere in the no man's land, as we see here. And this was a classical lesion which presented with a STEMI here because of perhaps LED. So the challenge was to fix most of the major vessels here because there was a distal left main plaque also in osteoproximal LED had a tight 99% lesion. And the dominant circumflex too had to be salvaged. This was the picture after the surgery, and you could see that LED is not filling from the Lima. And I'm amazed that how does it happen? I had to discuss it with the cardiac surgeons that how can it happen that the Lima is going to no man's land and LED is just not filling. So anyway, we started doing it, and it was far too early after the bypass. Within 3 months' time, the guy had landed up with us. So most of the three vessels, which are very precious, were wired, including a ramus, the circ, and the LED. The plan was to do the hybrid kind of approach here, utilizing different techniques of bifurcation. So dominant circumflex is very important, and ramus was precious, which could have been lost if you're not careful. So the first attempt was to salvage the ramus by putting a stent in the ramus and doing a kind of mini crush in the circumflex artery. And this is what we saw at the interface, the different vessels arising from the trifurcation. Then a stent from left main, as was the case in Dr. Viveka's presentation, that left main to LCX was placed. And this bifurcation at ramus and circumflex was dealt with a crush strategy. And then a tap was followed for the LED, which was the real culprit vessel for this acute coronary syndrome, and followed by kissing and a tap. And the whole thing was being done through 7 French guiding catheter. And this was the final result. And this guy is doing well till date. So this is just a chart drawn from the European Bifurcation Club, which clearly says that you should try to be provisional as much as possible. However, if you need to salvage the side branch, you could always convert your technique into tap or a culotte, depending on the angle of bifurcation, and try to make it as simple as possible, although DK crush has been shown to be the most efficacious technique, but with the caveat that not many operators are confident about performing a perfect DK crush. So one should try to follow the technique which you mastered, and patient safety is foremost, and try to use imaging as much as you can in your presentation. Thank you so much.
Thank you so much, Dr. Chandra, for those two very amazing cases, beautifully done, meticulously done. And I think Dr. Chandra has elucidated how imaging really helps us to find out where we went wrong in the initial procedure and how we can go ahead and solve it. Also, the importance of we do, come into a procedure with a certain set of ideas, but in the middle of the procedure, as the case goes, we innovate and we change a procedure. Provisional, as we know, has been the way to go according to the ABC guidelines. But in a situation like this, which he demonstrated with a Medina 111, we would be forced to think of an upfront two-stent strategy, especially in a scenario like a left main bifurcation where there's a huge amount of myocardium which is being subtended. We had beautiful end results in both the cases, and imaging really optimized it. So at one point, Dr. Chandra, I saw the place where you had that hematoma and you squeezed it with a balloon. So my question to you was, would you think of using a cutting balloon in that situation when you have a hematoma over there?
Yeah, if it doesn't resolve to the balloon squeezing technique, then the last resort could be just to perforate it either through a tough wire, as we do in CTOs, or even a cutting balloon can help to resolve this hematoma, go into the different layers. So that would have been one approach, and that was there on my mind. But for me, the squeezing helped, and then putting a stent actually, pressed it all along the wall.
So
Uh,
any comments from the
Good morning, Dr. Sarita, Dr. Subhash. How are you, sir? Excellent cases, if I may. And I thought maybe it is difficult to sometimes negotiate a cutting balloon through the stent. So maybe that is why perhaps choosing a normal balloon was initially a sensible choice. And if that had failed, of course, you could have gone on to a cutting balloon. But in the second case, sir, I wanted to ask you where you first stented from left main to circ, then you stented the LAD by a tap stent
Yeah,
using the tap procedure,
yeah, it was
and then you did the kissing balloon in the LAD and Ramus.
I first did kissing in the Remus and LCX,
Okay,
and that was fixed. And the second instance, I did kissing in LED and left main rem and left main circumflex, not
okay.
the Remus. Yeah.
Not the Ramus. Okay,
No,
I wasn't clear about the sequence of events there. But sir, since LED was the culprit, why did you use that as the tap stent, and why not first stent from left main to LED and then stent the circumflex?
yeah. So that was playing on my mind, and I would agree, Arun, with you that going left main to LCX should be the last resort. But there are some compelling situations where the sizes of these vessels match best to give us the best result, and we are always worried about the angulation at the left main circumflex origin, which perhaps could be best dealt with by this way of doing it. So in my case, the sizes of LCX and left main were more congruous than the size of left main LED. And luckily for me, LED was still flowing. So I wanted to treat it as a side branch, but I agree with you that should be the last resort. It should not be the preferred option.
But I think an excellent result, sir.
Thank you.
And the patient is doing well. That is the final scenario. Right. Great. Thank you.
Dr. Sarita, if you allow, I can ask a question to Dr. Chandra.
Sure.
Sure, go ahead.
Yeah. So, Dr. Chandra, great cases, and I know it's an Abbott session, but you demonstrated very good use of IVUS guided PCI in ACS setting, and Dr. Viveka had shown us the OCT guided PCI. So, what's your preferred go-to modality? I mean, does the type of lesion play a role in deciding which imaging modality would you use? I think on top of it, the fact that both were done with imaging is definitely great for the patient. But any thoughts on your preferred modality?
So, although Manish, I'm participating in Abbott Symposium, but to be truthful to you, I am confident on IVS, and I find it almost harmless, especially by virtue of its profile and not using contrast, and then mastered the interpretation of IVS. Although for the newer generation of cardiologists, OCT looks very catchy because the images are pristine, and one can interpret them better than IVS. In IVS, there are still gray areas where we are confused and we never have any clue that what could be the underlying pathology. So, but I do use OCT also. Cases where I want to capture nice images or want to be sure about the stent position, or maybe using a bioresorbable scaffold. There, I always prefer to use OCT. But for me, both are equally good. There are situations when the vessel size is very large where OCT would not be able to help me. I always go to IVS. And in left mains also, I largely use IVS in my practice.
Fair enough. Thank you.
So just to go ahead on that question, that is a question which is always asked. And I always say that both the imaging modalities have their own places. Now, having said that, most cath labs in India and I think across the world would usually have one imaging modality. Most cath labs don't have both. But typically, if we are doing ostial left main or if we're doing a proximal part of the left main, we typically like to use IVUS. Now, having said that, if a cath lab has only OCT, there's still a way to use OCT in doing ostial left main also, because you could take the telescope in and image with it, because the proximal part of the telescope is infrared compatible. So the OCT can see through that, and you can use the OCT for that also. Also, we know that whenever we have a patient with renal dysfunction, we like to use the IVUS in that situation because of the contrast issues with the OCT. But having said that, we've even done a live demo in a patient with using saline OCT. But then using saline OCT has a learning curve. You have to learn how to get the images beautifully using saline in place of contrast. So I think typically the images that we get with OCT are very clear and very easy to understand. And but however, in cases of nephropathy, in cases of left main situation, if a lab has both, they do prefer to use IVUS. But then both the modalities can be shifted to use in the way that you need. What is very important to understand is this is not a battle between OCT and IVUS. Both have their places in PCI. What is very important to understand is that a procedure is much better if you use imaging in it. The outcomes are much better. The long-term results are much better if it's an imaging equipped procedure.
Absolutely. Absolutely. Thanks for those comments, Dr. Savita.
So if there are no more further comments or questions, Dr. Chandra, those were two very beautiful cases, and they typically bring out the adrenaline in an intervention cardiologist in the lab. So we'll move to Dr. Samir Dani, and he's going to be presenting acute MI with cardiac rupture. Again, Dr. Dani is a chairman and director at Apollo Hospitals, Ahmedabad. Over to you, Dr. Dani.
Can the backend team please help connect Dr. Dani?
Yes.
Dr. Dani, you're on mute. Could you unmute yourself?
थोड़ा समय પછી પ્રયાસ કરો.
Is Dr. Dani connected? I can't see him here.
He was connected, Dr.
He
Chopra.
is
earlier.
connected. He's
Yes.
connected, but he's on mute.
We could see his picture also, so perhaps he is busy somewhere. So maybe
Pratima, could you call him? Maybe we can move to the next presentation.
Yeah.
While you
Let's do that.
connect with him, right?
Yes. Yeah.
So we'll move to our next speaker for the day, and that's Dr. Sanjeev Roy. Dr. Sanjeev Roy is going to be talking about the choice of DES in acute coronary syndrome. He's also going to be talking about thromboresistance and important considerations. So over to you, Dr. Sanjeev.
Hi, good morning, everybody.
Good morning.
Are my slides visible?
Your slides are visible. Could you go to slideshow, sir?
Okay, so I'm going to discuss about the choice of drug-eluting stent and ACS, specifically focusing on thromboresistance and other important consideration, including imaging. So there is a high burden of acute coronary syndrome, and particularly in terms of mortality and morbidity. The acute coronary syndrome nearly contributes to 50% of the cardiovascular deaths in AS. One third of STEMI patients die within the first 24 hours, while if you look at the NSTEMI, 15% of them have a death or a non-fatal MI within 30 days. However, there's a catch-up phenomena, and the event rates almost equalizes each other at 6 months' time. If you look at the CREATE registry, that is acute coronary registry in India, this was nearly from 89 centers from 10 regions, 50 cities, and included about 21,000 patients. Here in the ACS, nearly 60% of them were the STEMI patients. Mean age of presentations were 57 years, STEMI being younger than the NSTEMI patients. And most of the patients were in the lower middle class, or they were 20% of them were in the poor social class, where if you look at the penetration of the treatment, be it the intervention or the pharmacological proven drugs, they were very, very poor. The mortality was nearly about 8% in STEMI patients, 3.7% in the NSTEMI patients. But in a nutshell, what was concluded was the poor are less likely to get evidence-based treatments and had a greater 30 days mortality. The most importantly, if you look at the recurrence of cardiovascular events, which remain unacceptably high after an acute coronary syndrome, and this is 1 in 5 patients who suffers from another vascular event in the first year, and 1/3 of them have recurrent events which lead to mortality. And those who had an event-free survival in the first year, if you look at in after 2-3 years, again, 1 in 5 patients have some kind of events in the next 3 years. And most of these events, if you look at the risk factors, are related to age, diabetes, having had a prior MI, and a chronic kidney disease. So in other words, cardiovascular event continues to occur over time in acute coronary syndrome. And this is what the REACH registry showed, that every year followed up for the 4th year, this keeps on increasing. There is a cumulative increase of all the events. And more so, if you look at the ischemic factors which are to be washed out, are the elderly age, multivessel disease, chronic kidney disease, diabetes, prior MI, and prior building risk. So let me take you to a case. This was a 67-year-old gentleman with 2 days history of ongoing chest discomfort. He's diabetic, hypertensive, no tobacco use, no history of premature coronary artery disease. ECG shows acute STEMI. Echo shows moderate LV dysfunction with hypokinetic LED territory. Troponin is elevated. The glycemic control fair, normal renal function. So straightforward, there was a tight lesion bifurcation in the LAD diagonal. Went ahead with the stenting. This was a provisional approach. A stent was 2.75 into 38. Did a pot with 3 into 10 and a distal optimization with a 2.75 into 15. So far, the result looked good, but a careful analysis in the caudal views looks some kind of haziness proximal to the stent. So the stent apparently was the lesion was apparently well covered. Now, what could this happen? The haziness look like? It was something like crater-like filling defect. Now look at the OCT views here. So here, let me run you to the OCT. This is after the placement of the stent. And can I use the control? Okay. So what we could see is proximal to the stent, there is a plaque rupture and a lot of thrombus proximally. So if I show you the images here, let me use the pointer here. So you can see here the sites of plaque rupture, which was much more proximal to the stent. And this reminded to me of one of the, lectures that I attended long back in TCT during my formative years. And the culprit lesion, the ACS, may not be the tightest lesion, and that needs to be in your mind very carefully. So this was something like, it's shown in this cartoon where I had stented the tightest lesion, and actually the plaque rupture was much proximally. So obviously I needed another stent, and that stent covered the entire lesion right from the ostia. And this was 3 into 23 Zine stent, post dilated with 3.25. The final results looked quite beautiful. And this was what the final result is. And here, of course, there was some edge dissection. You can see here, which was non-flow limiting beyond the distal edge and just was left like that. The ostia was right, nailed proximally, sparing the bifurcation. Let me take you to another case. This is a 70-year-old lady who had presented with dyspnea and uneasiness for 3-4 days. She was evaluated, and where ECG showed inferior STEMI, almost like evolved, hemodynamically unstable, inotropes were initiated in the emergency. She's non-diabetic, not a known hypertensive. Echo showed moderate LV dysfunction with wall motion abnormality, and troponins were markedly elevated. Creatinine was 1.77, and these are the angio pictures. Now, because it was hypokinetic, so I didn't think that needed a viability assessment despite the presentation being more than 48 hours, because you can see some, trickling of contrast here. So some filling might be happening here. This was totally occluded. Now, when I wired, huge, amount of thrombus burden, tried to do thrombus suction even by, deep embolizing of my GR catheter, which partially helped some flow, but the lesion was quite hard. Used a cutting balloon to break the lesion, and this is how it looks like. You can see here the thrombotic lesion out here and entire embolized thrombus right down to the PLV branches. So this was a good case for using a penumbra, and because of the large burden of the thrombus, and penumbra did help me to, aspirate out all the thrombus right up to the PLV branches. And if I can look at, this is after the thrombus here and some PLV branches, and then straight away stented with a 4 into 48 millimeter stent. And this is how the result looked like after thrombus aspiration adequate and the stenting done in a STEMI patient with a delayed presentation and organized thrombus. So the key factors that impact the outcome are the acute coronary syndrome, particularly the type of acute coronary syndrome, the time of presentation, and the amount of the thrombus burden. Ischemic risk factors, mostly related to age, diabetes, CKD, and anemia. And the kind of antiplatelet drug that we choose, or the GP2B3 inhibitors, type of intervention, whether it is primary, early intervention versus delayed, lesion complexity, need for plaque modification in complex cases, the type of drug-eluting stent, and the intracoronary imaging. And I'll be focusing on the last 2 points more importantly. So the key essence in acute coronary syndrome, particularly the acute MI, STEMI patients, is a very early reperfusion, which helps you to salvage the myocardium. And beyond 6 hours, it is mostly an open artery that helps you to remodel the ventricle. So time factor is very, very important. The second factor is the choice of antiplatelet drugs. With current CPTP inhibitors that we have in form of ticagrelor, which acts both in the P2Y12 pathway and the adenosine, has an edge over the thienopyridines, which act only through the P2Y12. But remembering thereby that we have to balance the act, we might need a longer, shorter DAPT in those with the bleeding risk. And we have to recognize those who are a high bleeding risk so that we can choose our antiplatelet and stent with an early endothelialization in a better way in such kind of patients. So choice of contemporary DS, does it impact? Yes, what I'm going to look for is in general an easy deliverability of the stent in complex situation, which makes the vessel patent with minimal new intimal hyperplasia, rapid endothelization, and less risk for stent thrombosis. So what matters is not only the delivery system, but the stent platform, drug, and the polymer coat. So if you look at the stent platform, we have a ring which are connected to the adjacent rings with a connector. And this substance is cell space, which again, very, very important for access to the side branch. And each of the ring has a crown and the struts, which actually form the crest, and the number of crest also decides on the expansion capability of the stents. So what actually the bench tests do for the approval is just they look at the foreshortening, the stent integrity, the acute coating durability, and chronic coating durability. But for me as an intervention, what is important is I need a stent with a radial, with a high radial and axial strength, large overexpansion range, which can scaffold even when I have overinflated the tissue, particularly in acute coronary syndrome, preventing thrombus and plaque prolapse. Help me to accurately place the stent, particularly in osteal stentings, which is less thrombogenic and has a less inflammatory polymer and better side branch access. So here, if you look at the stent design, that also has important as far as the longitudinal and radial stability is concerned, and they can cause the plaque prolapse, deformity of the stents, which requires, again, sometimes you might find an abnormal abdominal wiring. You might need an additional stent to correct as far as the acute impact is concerned. And chronically, if you look at this impact, this based on stent thrombosis, restenosis, and vessel injury. So Zymes has a polymer, which is, though a durable polymer, which raises a concern about the inflammatory and the thrombogenicity. But if you look at the representative conofocal photomicrographs, this has the least, platelet adhesions and the least adhesions for the macrophages. That makes it more safer, and we call it thrombopassivation. So stent design matters, and what we need is an evidence, and these evidence, we have a robust evidence as far as the Zymes platform is concerned in all kinds of scenarios. If you look at the STEMI patients here, we have the examination trial, the Zymes STEMI registry, STEMI 4 and Trophy. One of the recently published was the host-reduced polytech acute coronary syndrome trial, which was an investigator-initiated open-label randomized multicentral trial, compared all kinds of platforms, and Zymes showed an excellent outcome compared to all other in terms of reduction of both the patient-oriented and device-oriented outcomes. Does imaging play a role? And I think Viveka already pointed out here. Yes, imaging plays an important role because there are inherent weakness of angiography in ability to accurately assess the vessel size and lumen geometry, in particular in the acute coronary syndrome, where vessels might be in vasospasm. The components of the plaque accurately detect the presence of thrombus. And imaging helps us to actually understand the mechanism of the acute coronary syndrome and, to look at the plaque discontinuity disruption. More importantly, it helps us to recognize also the non-atherosclerotic causes. And this was what was highlighted in the algorithmic drive, where it plays an immense role in differentiating obstructive, non-obstructive CAD and the choice of treatment in accordance. So these are the lesion morphology that you can pick up in OCT, which has an advantage over IVUS in cases of acute coronary syndrome, where we can actually identify the plaque eruption, the eruptive calcific nodules, and thin cap fibroadenoma with thrombus very clearly. So to conclude, acute coronary syndrome are a complex subset of a high risk with a high risk of MACE, MI, and stent thrombosis. And in India, they tend to be younger from lower socioeconomic groups, have a higher rate of STEMI than do other patients in the developed countries. While the milieu is excessively inflammatory and hypercoagulable, but those at high risk bleeding need to be identified as well. The use of key medical evidence-based treatments are important, but timely intervention, reperfusion, and or revasculation is very crucial. During PCI, key to the febrile outcome depends on the type of the stents that you have used, which have a proven safety, durability, and less thrombogenicity, causing less plaque prolapse. And imaging helps you to identify the culprit lesion and plaque etiology. Thank you.
Thank you, Dr. Sanjeev, for that very wonderful presentation and your focus on the two very important points when any of us do a procedure is choosing the right stent for the right lesion. And because many a times we've seen that, we're doing a bifurcation disease where we need a good side branch access. We are using a long lesion stent where overexpansion of the stent is very important because the proximal vessel might be a 3.5, but the distal would be a 2.5. And again, in left main bifurcation, when you have a discrepancy in sizes and you need overexpansion capacities, and of course, the thrombogenicity also really matters. And the use of imaging, which we've been discussing all along, how beautifully it helps to improve your procedure, especially when you demonstrated in that first case. It was very interesting that the angiographic picture which you saw, and then when you imaged, you found out what was the issue over there, and you were able to deal with it and avert a typically catastrophic situation. And then again, at the end of the procedure, when you took the imaging run and you found that dissection, and you knew that it was safe to leave it because it was just not even one quadrant. So how beautifully imaging helps us in doing a procedure and how the uptake of it has to grow for all of us. And the choice of stent also really matters. So any questions from the panel?
Uh, Dr. Sanjeev, an excellent case and an excellent demonstration of the benefit of OCT, as Dr. Sarita also just mentioned. I think this goes largely to explain why there is a disconnect between the results of antiplatelet trials and the result of short DAPT trials, which are done by stent manufacturers. You might have wondered why all the DAPT trials say that you changing from clopidogrel to from ticagrelor or prasugrel to clopidogrel causes increased events in the first 1 year. But these are not seen in the stent trials. When we stop DAPT after 3 months or sometimes even after 1 month in high bleeding risk cases, this is because those are optimized PCIs. Those are cases which have been tackled with completely by using imaging, as you have done in your case. And had you left this case, this patient would be a likely candidate to get another early ACS. So excellent, excellent demonstration.
Thank you.
Dr. Roy, great case and great talk. I think continuing with the point that Dr. Arun mentioned on the role of antiplatelets. So you also mentioned that high bleeding risk, especially in Indian patients presenting at a much younger age and often with diabetes and associated problems. So do you see role of imaging in tailoring your DAPT therapy in these cases?
Absolutely. In all those in high bleeding risk, I prefer using any imaging modality, whichever is affordable by the patient and whichever is available to get you a good optimized result. That actually instills confidence in me for early discontinuation of the antiplatelet therapy. And many times earlier also, some patients who used to come from a village background, they were not very conversant about the understanding of the antiplatelet drugs and the need to continuity. We used to find them, they have prematurely stopped the drug. And for academic interest, we used to do the studies, and those were the cases where we had given a good optimized result on the stent one, including left main, where patient has discontinued his treatment after 15 days because those drugs were not available there. So they just simply discontinued. And we observed that even on those crucial lesions where nobody would dream to stop antiplatelet for the next 1 year, and patient had discontinued and doing very great. So how did the endothelialization, of course, can't happen in the first 15, 20 days, but yet perhaps in some way, the fact that there was good expansion, no malapposition, and despite the patient not being in dual antiplatelet, kept the stent pattern, that gave us confidence on the image-guided optimization of the result.
I think Dr. Sanjeev, that's such a beautiful point that you've elucidated, because typically an imaging optimized procedure really gives you confidence for early de-escalation of dual antiplatelet therapy. Typically today, because we have a huge aging population, which we're doing procedures on, and more complex procedures, and also HBR patients, which are increased in the aging population. And I'd just like to share one case here that I did a patient who was very elderly, about 82 years, and severe LV dysfunction, and we did a left main bifurcation for that patient. It was an upfront 2-10 strategy, and it was under impeller support. And this patient, 3 months down the line, stopped all antiplatelet therapy and came after 15 days and said that, oh, I'm not taking any medication because I felt so good. And we were like, it's a left main bifurcation. There are upfront 2 strengths. This patient had severe LV dysfunction and had an impeller guided procedure, and nothing happened to the stents. We took a check shoot. So that's the beauty of image guided procedures, that you've optimized them so well that even early de-escalation of antiplatelet therapy is possible.
Dr. Sarita, we do have an audience question also in the chat box.
Let me have a look.
Yeah.
So the question here, throughout the history of metallic stents and STEMI, I think procedural acuity perhaps plays a stronger role to avoid acute early complications and less on the type of the stents. So Dr. Sanjeev, would you like to comment something on that?
Sorry,
So
please, can you repeat the question? I didn't understand that.
The question was, is it procedural acuity or is it the type of stents?
To decide for?
The results of the stenting procedure. I think basically what the person is trying to say is how good a job the operator did versus the type of stent which was used.
I think both are important, the skill set of the person who is deploying the stent, because many a time you may not be deploying it on the image guidance. But those who are doing it in image, they develop a skill set where they can give you a result which is as good as without using stents. And we have seen this in the recent trial on the OCT. What was that? The fourth series.
Occupy.
Not Occupy, the other one. It's the other
Uber?
Illumine. Illumine 4.
Yeah.
Illumine 4 did not show the great difference in the both subgroups, because the same operator who was doing image guided, those are the same operators who did the non-image guided. They gave the results as far as the expansion and the minimal stent area is almost as good as those being performed under image. So that is very, very important, because they acquire a skill set which can give you a good result. So skill set is very, very important, where you can give a result as good as image guided. And having said that, the platform, the drug-eluting stent, contributes further to ensure that the stents are durable, the results are durable. You have a lumen gain, you have a patent stent down the line. So both things do contribute. So difference, if you look at the BMS as well as DS, yes, the skill set is very important to give you the acute result, but DS contributes to maintain that result down the line as far as the patency result is concerned.
So that's typically what even I would agree with, that when there is a complex lesion involved, the skill of the operator is always important. At the same time, image optimizing of the procedure is very important. And finally, the stent type also does play a choice. So I think all of these 3 things together help us in helping the patient to have a great optimization of the procedure and long-term results, which are really good. I think we've been joined now by Dr. Samir Dani. We were calling him earlier, and I think he got involved in some case. Thank you, Dr. Sanjeev, for that wonderful presentation, and the fact that imaging and the type of stent really help you in getting great outcomes. So over to you, Dr. Samir Dani, for your presentation.
Yeah, hi everybody. I was just away for a few minutes to look at the match. I was not in any procedure. I missed out. I'm sorry for that. Okay, so let me share my screen.
So what is typically the situation of the match right now?
It's interesting. The last I saw, they were 9 down, and for last 20 runs, we have not been able to take the 10th one. So those 20 runs are going to be golden ones for Australia. Hopefully, we'll still have a target which is achievable for Indian batting lineup. It's time for them to click. Anyway, so I'm moving a little away from the technique, the technique, the stents, and even imaging, if at all one can say that. I'm going to talk about some very basic imaging, that is echo, not anything intravascular. And I'm going to talk about a case where treatment strategy becomes important, diagnosis becomes important, and how or what you think, and that becomes very important. And at the end of it, to a certain extent, the futility of uh, medical intervention at times strikes you. So let me start. Can you see my screen well?
Yes, we can see your screen. Please go ahead.
Okay. So this is a case of STEMI with pericardial effusion. Okay. So this gentleman, 74 years old, male, fellow cardiac anesthetist in another hospital, hypertensive and dyslipidemic for many years, and his angiography was done in 2012 for some non-specific symptoms. He had non-obstructive coronary artery disease then, and he was on medical management. The major risk factor for him was his blood pressure was well controlled, his cholesterol was not that well controlled, but major risk factor for him was sudden cardiac death in his father at the age of 55, and both his elder brothers died around the same age. And he was feeling little lucky for not having sustained any coronary event until this age. He had complained of severe interscapular pain for 4 or 5 hours, on even more on that day, early morning. It was Sunday, and that was associated with excess fatigability with minimal exertion starting the evening, previous evening. He had maximal pain in the morning with perspiration, no actual dyspnea at rest, no syncope or loss of consciousness. And he presented, his ECG was taken, which was showing infralateral infarct. When he presented to us, he was hemodynamically relatively stable. The blood pressure was in lower normal range. Nothing in particular in his blood workup also, except that troponin was very high. And this was the ECG taken at home, and this was the ECG on presentation. You can see minimal ST elevation in 2-3 AVF and lateral leads V5, V6. Nothing much to suggest anything very grave at that particular point of time. But when we did the echo showed inferior hypokinesia, mild LV dysfunction, and some pericardial effusion. So very mild MR, sclerotic aortic valve. The PA pressure was mildly elevated around 41. Compared to the systemic pressure, it was slightly high, but the pericardial effusion around RV side was around 10 mm. He was already given loading dose of ticagrelor, disprin, and atorvastatin. Tirofiban had already been started, and he was urgently shifted for coronary angiography on that Sunday afternoon. Angiography, I'll not go descriptive, I'll just show you the angiography. Right left main, LAD, significant lesion, and a little bit surprisingly slow flow, which happens with acute MI situation in non-culprit vessels also, especially when they are diseased, and circumflex lesion, mid-circumflex lesion. By that time, we already knew of his pericardial effusion, and we kept on monitoring his effusion, even on table. We did echo, and this was the picture of the right coronary artery, thrombus-filled PLV. What next? Obviously, the PLV was culprit, so we decided to tackle that. And prior to that, since his blood pressure was around 95, we inserted IABP. No inotropes were given, and a little bit of fluid was given, but that made him a little uncomfortable. So we proceeded with the angioplasty. Thrombosuction was done, which yielded some flow, some more thrombosuction, and gentle dilatation with the balloon. And then some more flow, then prolonged dilatation with a long balloon. Very gentle. All the dilatations were less than 6 atmosphere. And then we achieved some flow. And as you can see, it was a very, very large PLV circling to the base of LV. He was kept conservatively after that. The options were discussed, and we kept an eye on the pericardial effusion. Seemed to increase a little, not much. He was hemodynamically stable. We discussed the option of CABG, and he promptly agreed. The surgeons were involved, and they decided to do his surgery after 48 hours. On careful echo, done multiple times, we could not find exactly the site of rupture, nor there was IVS also appeared intact. It looked as if it was around apex, but we were not sure. After the angioplasty was done, as I said, his surgery was planned after 40 hours. He was on single antiplatelet, high dose statin, single shot of enoxaparin. Tirofiban infusion was stopped after 100 ml, and he had IABP on, and the IABP gave us reasonable augmentation, as you can see. He was stable on the day 2 after the angioplasty. He talked to us. We planned out everything and lots of discussions, and he was pretty confident and happy, actually. And then he suddenly became unconscious and gasped for breath while talking to the doctor on duty. And the ECG had a flat line. There was no preceding arrhythmia, no VTAC, no ST elevation. We went back on the central monitor, and the ECG just stopped. And when we did echo, this was echo 30 minutes before this happened. And this was the echo immediately when this happened. There's a large clot, and this was like few minutes after CPR. After intubation, ventilatory support, ongoing CPR, we did the pericardiocentesis, many cycles of CPR and all that, and patient was lost. So the discussion points are probably, to my mind, was the decision to do the primary PCI appropriate? And if we did the primary PCI appropriately, what more could have been done? Should we have intervened on LAD and LCX and LMCA all as well? All were doable lesion without waiting for the CABG. Would it have altered anything? Whether intra-aortic balloon pump was a good step or a bad step? Could tirofiban have been stopped early rather than giving 100 ml? Should bypass have been done earlier with its attendant risk, but within 24 or 36 hours? Could transesophageal echo have helped us in making decision about bypass? Was there anything at all that could have been done to save this patient? He was a fellow doctor, remember, a cardiac anesthetist. And what should be done if one can encounter such a situation again? So the thinking went like this. The presence of pericardial effusion had already alerted the team. Hence, no stent was implanted in PLV in case the APT need to be stopped or not be given, and it was not given after the initial loading. And that's exactly why left main LAD or circumflex stents were not planned. Maybe plain PCI could have helped, but in what way? Getting the blood pressure right, but not in preventing the myocardial rupture. And that's why intra-aortic balloon pump was inserted, and not any inotropes, no other anticoagulants strategy except single shot of enoxaparin on the next day. Uh, Transesophageal echography was not done to avoid straining or not to avoid inconveniencing the patient. Entirafiban was stopped at 100 ml, could have been stopped earlier, and the toss-up was between allowing the possibility for infarct to expand in absence of tirofiban versus become hemorrhagic with tirofiban. Anyway, CABG was planned and was planned early, not earlier, because to mitigate the surgical risk, and the patient looked stable. So the thinking points or learning points from this case for me were early echocardiography to detect pericardial effusion can detect a population with high risk of death and who deserve close monitoring to detect free wall rupture and hopefully to allow time to react before sudden death. But even then, we may not be able to salvage these patients. But presence of pericardial effusion itself on the day of MI, early pericardial effusion should prompt the search for a possible rupture and earliest possible intervention. When the pericardial effusion in parasternal short axis view exceeds 10 mm, the risk of free wall rupture is particularly high, and that has been shown by one of the largest pericardial effusion in acute MI series. Measurement of hematocrit, if you can tap, may be valuable if you are doubting the diagnosis of free wall rupture, because if hematocrit is high, then it is free wall rupture. But anyway, the diagnosis is of little help when you are sure in presence of moderate PE that there are no other circumstances where pericardial effusion could have happened, and then you should suspect free wall rupture. Avoiding intense anticoagulation, intense antiplatelet strategy, close monitoring, early surgery, these are the cornerstones of treatment strategy. But all these can fail, and presence of moderate pulmonary pericardial effusion early in acute MI means free wall rupture until proven otherwise, and it means a grave prognosis with that particular series showing mortality, 30-day mortality of upwards of 40% in patients who had any signs of cardiac tamponade and 20% in those patients who did not show any early signs of cardiac tamponade. So very sobering points and very different or kind of significant departure from our thoughts about acute MI and techniques and stents. But I thought that this was an important case which I encountered lately. Thank you.
Thank you, Dr. Dani. That is a very interesting case. And typically, this is a kind of case which most of us at some point in our career do experience. And it's always a challenge to deal with this kind of a case because acute MI situation means we always like to anticoagulate. And in the presence of a thrombus, we always like to use 2B3A. Now, in hindsight, when we think about it, we think that possibly in the presence of effusion, maybe we should not have used it. But in the presence of a clot in the PLV, you would have always wanted to use it in an ACS situation. The second is that the fact that we typically had a similar kind of case twice. And in one case, we lost the patient, like you did here. And in one case, we saved the patient. And I'll talk about the save because the save was important. And it typically happens in the same way. My patient was also a patient who had an RCA lesion. And we had done a ballooning. We had also not put in a stent. And this patient suddenly collapsed. Luckily, we were there and we immediately did an echo and we found the same kind of finding. And we knew it was a rupture, emergency pericardiocentesis. But there were such huge clots, nothing was coming out of the pericardiocentesis. My surgeon immediately created a pericardial window bedside. And we started auto-transfusing the patient and shifted the patient on systolic pressures of 50 to the OT. And an emergency surgery was done. Patient was again shifted down on pressures of multiple inotropic support, IABP, everything. And that patient actually made it because of the emergency surgery, and possibly because he created a window bedside, sucked out everything, and we kept auto transfusing everything that we were sucking out. And that patient made it. But the other one did not make it, had a bedside arrest, and we could not revive. So these are very challenging situations, very high risk. Most of the times, we're not able to save the patient. But over to the house for comments and comment.
Uh, Dr. Dani, I think a very interesting, as you said, very sobering and a very educational case. But I would like to disagree here somewhat. Uh, I have had nearly 10 such patients, and in 6 patients, we diagnosed the patient with the pericardial effusion in the ER. And I sent 6 of these patients to OT without even doing a coronary angiogram because they were all in hypotension shock. Two of them had MIs in the last 2 to 3 weeks, which had been managed conservatively with thrombolysis outside. 4 of them were relatively acute, and they were all within 24 hours. So in these 6 patients, I did coronary angio in only one, and the other 5 survived. The one in whom I didn't do coronary angio prior to surgery, I just sent them for a repair of the perforation based on suspicion alone that they have an acute MI and they have a probable leak there. And they all survived. I did their coronary angios after the surgery. And in most patients, I didn't have to do anything. There was just one infarct related vessel which was occluded, the rest of the vessels were normal. The one patient in whom I did the coronary angio, actually they did CABG because there was some other disease. That was the patient who didn't survive. There were at least 3 other patients in whom we did coronary angio, and we thought we'll stabilize them before sending. This is earlier, much earlier than that, maybe 10 years ago, and none of them survived. So I think my experience is in the last several years that when we diagnose them in the ER with an acute MI and with a pericardial effusion, especially in the first 24 hours, or if it is late, as I'm talking at 2 or 3 weeks, when you have a pseudoaneurysm and a probable leak, in both such situations, it is early surgery which helps. And opening up the vessel actually does not help. It actually makes things worse. Just as in VSD, all survivors of post-infarction VSD, most survivors actually are those who have early septal closure or septal repair rather than the ones who get revascularization. So I think surgery here is probably the key to go, though you bring out several very interesting points.
Well, the difference here is that this was within 6 hours of acute MI. This was not a thrombolized case. Thrombolized cases rupture more easily, that is true. And in first 4 to 6 hours, still the standard of care would imply that you do angiography and you do PCI. And another interesting point is that one of the largest, I mean, the largest, not one of the largest series reported of patients with acute ST elevation MI and pericardial effusion, they showed that the results of surgical intervention did not change the mortality. Now, this is debatable because, of course, the patients who go for surgery are obviously likely to be more sick, and that's why they were taken up for surgery early. But early surgery also did not change the outcome, the mortality, which was in excess of 40% in these patients. So yes, probably early surgery, but the problem is that when the patient is stable and when the effusion doesn't seem to be increasing, the surgeons would like to wait for 24 hours more, 12 hours more, or little more, and then take him up so that the surgical risk is mitigated. But in presence of moderate pericardial effusion, especially more than 10 mm, it is probably, as you said, it is prudent not to wait and go for early surgery, no matter what the risk. As the surgical techniques improve, probably we may be able to save more such patients.
I think the
Great,
take-home
thank you.
message is that if we are having moderate effusion, and it's important that we call in a surgeon early.
Yeah, and especially this is the effusion detected in ER. I mean,
Absolutely.
effusion which you detect on second or third day, or effusion which you detect while doing the PCI, you have to look for other causes also. But including acute, some people have reported acute infarct-related pericarditis. But those conditions run a very different course compared to a free wall rupture.
Right.
Yeah. I think in the interest of time, we move to the last talk by Dr. Chopra. Dr. Dani, there was also a question in the chat box. If you can type in your response there, would be great. But over to Dr. Chopra.
So I will like to hurry it up a bit because this is the last talk and I think we are running out of time. I hope you can see my slides, Dr.
Yes,
Sarita.
we can see it. We can see it.
Sure. So primary PCI in an anomalous RCA, and I will also just very briefly mention choice of stent and drug-coated balloon. So this 68-year-old female was referred to the OPD with history of chest pain one day earlier, and she was referred because of these non-specific STT changes. On evaluation, she was a short stature 50 kg female, asymptomatic after one episode of pain for over 24 hours. And known hypertensive, BP was well controlled on medication, and echo was done immediately in our hospital. That was normal except for mild LVH. HS troponin T was negative. Stress echo was negative at 7 minutes with adequate heart rate achieved. So she was sent home on addition of beta blockers and a Disprin at Orvastatin combination with advice to review after 1 week. But at 7 p.m., I agree and received a call from the ER that she had had chest pain again with ongoing pain for 1 hour. She had acute inferior MI and she had regional wall motions abnormality in the RCA territory, ejection fraction of 45%, hemodynamically stable. So we took her up immediately for a primary PCI with a right radial access. The left system was normal. The RCA could not be found arising from the right sinus of Valsalva. So a non-selective shot was done higher in the ascending aorta and that revealed an anomalous high origin. So a JL4 diagnostic catheter revealed it to be arising from the left sinus of Valsalva, close to the origin of the left coronary artery. But the guide catheter could not cannulate it from the right radial approach. So we shifted over to the femoral approach due to ongoing severe pain and hooked it with a 6 French JL3 guide. So this is unfortunately, I don't have the earlier diagnostic angio shots available, but as you can see, it was cannulated with the JL3 guide. And after a balloon dilatation with a small 2 millimeter balloon, there was still a lot of thrombus burden. And I did attempt taking a thrombosection catheter in, but the guide catheter support was inadequate. So we did multiple balloon dilatations throughout the course of the RCA and managed to open up the vessel a bit, got into the large PLV branch, had to do multiple balloon dilatations because a thrombosuction would not go in. So as you can see, after doing several balloon dilatations, flow appeared in the two branches. And after doing this dilatation here in the distal PLV as well, the whole right coronary artery opened up. And we decided to then stent just the culprit lesion because I was presumed that the remaining part was basically a thrombus-laden artery. So took a Zine Sierra 2.75 28 millimeter balloon, stent, and post-dilated it with a 3 millimeter balloon and had a good result in the right coronary artery. And she could be discharged 2 days later and is doing well on follow-up. So I thought I'll focus a bit on two things. One was anomalous coronary arteries, and second is choice of stent in acute MI. So I'll discuss them very briefly. So anomalous coronary arteries are found in about 1% of all angiograms. And anomalous RCA from the left sinus of Valsalva accounts for 6 to 27% of all coronary anomalies, but may be responsible for rare sudden cardiac arrests. In fact, it was found that 17% of sudden cardiac arrests in young males occur because of this anomaly. So the guides that are most successful in cannulation depend upon the site of origin in the left sinus. And they may be a Judkins left guide, one size smaller or larger than the one used to cannulate the left coronary, the EBU, or the left emplots. So these are the commonly used guides. So I'll just show you, this is just a brief cartoon showing the normal origin of the RCA from the right sinus. But there can be several anomalies here. So we can have anomalous origin of the right coronary from the right sinus, as we can see here, a more anterior origin. We can have anomalous origin of the right coronary artery from the left sinus, and there are these three sites which I'll just show you subsequently. And there can be the origin of right coronary artery, which is very high from the ascending aorta above the sinotubular region. So the most common variant when we don't find the RCA in the usual location in the right sinus is an anterior origin of the right coronary artery, as you can see here. And this can often be cannulated with a JR4. We just have to uh, differently position the JR guide. We have to try to make the catheter point towards the operator in the LAO view, or we can switch to the RAO view, where we find that it is a anteriorly arising RCA, as you can see here. So if a JR does not work, one can switch to an Emplott's left 0.75 or 1 or an AR2, and typically that would cannulate this. But this is an RCA arising from the right sinus, though from an abnormal location. There are other anomalous RCAs, as in this case from the left sinus of Valsalva, and these typically have three locations. So they can have a location just above the left coronary artery, they can have a location just below the left coronary artery, or they can have a location in the middle, close to the point between the right and the left sinus of Valsalva. Of course, there can be high origin, as you can see here, high origin from the ascending aorta above the sinotubular ridge. So this is a variety of these anomalous RCAs which have been cannulated with an Emplott's left. But for a quick approach, you can remember these three ideas. If the right coronary artery arises from the left sinus of Valsalva, the most common origin is A. This is just above the origin of the left coronary artery. And here, typically, a short JL will work. A Judkins left, which is one size smaller, would work best. Sometimes you need a larger size, but typically, since this is above the left coronary artery, a one size smaller left than you used to cannulate the left coronary artery would work best. If the configuration is inferior, as in B, then a EBU catheter or sometimes an XB catheter, but typically an EBU catheter, which is looking down rather than looped upwards, would work best. And if it is in a position C, which is in between, near the midline, between the right and left sinus of Valsalva, the Emplott's left would work best. And this is the experience from the largest series in India, which has been published by Dr. Vijay Varghia and colleagues from PGI Chandigarh last year. They had 35 cases of anomalous RCA from the left sinus, and they used the Emplott's left in 21 cases and the Judkins left in 12 cases, EBU in one case. And these are just images showing how they cannulated the arteries. This is another series from Madras Medical Mission, Dr. Ajit Maslasri's group, again showing that they prefer to use one size larger Judkins left or an Emplott's for most of their cases. But this is a summary briefly showing what should be your choice of guide catheter for anomalous RCA from the left sinus of Valsalva. Coming next to a brief overview of stent use in acute MI, there are many trials, as you can see, BioSTEMI, Trophy 2, Comfortable, Examination, ZAMI, and RACES MI. So all these trials have compared durable polymer stents, drug-eluting stents with BMS, and examination trial with Zymes showed superior results with durable polymer EES in comparison to bare metal stents. However, recent data suggests that biodegradable polymer DES may have some advantages, and this recent Korean meta-analysis in over 10,000 patients, which was published in 2020, which compared Zymes Promus Resolute with Biometrics Nobori or Zero, suggested that there is some sign that net adverse clinical endpoints at 2 years may be better for biodegradable polymer DES than second generation durable polymer DES of the type of Zymes. However, what we need to know is that for the first 1 year, there is no difference. The change comes after 12 to 18 months, and these are relatively short duration follow-ups, only 2 years. The two large 5-year follow-up studies which examined this issue both reported consistent benefits of all newer generation stents with either durable or biodegradable polymers over DES. The final answer of durable versus biodegradable polymer DES is awaited, and hopefully we should get it soon in the next few years. Another strategy which has gained popularity is the use of drug-coated balloon in acute MI. And this meta-analysis published recently shows that there is no difference in all-cause death or cardiac death uh, between DES and DCB. MACE are also the same as is late lumen loss. Though if we look at TVR and TLR, this data still favors drug-eluting stents in comparison to DCB, which is, I think, obvious. So to summarize the stent use, second generation, all DES are better than bare metal stents. Thin struts are better. Biodegradable polymer could possibly be better than durable polymer, though we don't have data beyond 2 years. For 5 years, we have data with durable polymer EES. So if we have to summarize as to the best choices for stent use, they are durable polymer everolimus eluting stent and biodegradable drug-eluting stents. And DCB may be comparable to second generation DES in selected subjects. As to the final conclusion, a normal TROP-T and stress echo don't rule out an acute coronary syndrome. In select cases, please consider doing a CT angio, as happened in our case. While radial artery is the most common access for primary PCI, one should not hesitate moving to a femoral approach in case of excess tortuosity or anomalous coronary artery origin, as in this case. And so we move to the femoral artery to facilitate a quick procedure. A selection of common guides that must always be available in the lab include an Amplat's left and right, EBU or XB, JL3 to 5, and multipurpose catheters. The Zyme Sierra has a proven track record over 5-year follow-up in AMI cases, has excellent trackability with good radial strength, and it could track in easily despite the anomalous origin in this particular case. Thank you very much.
Thank you, Dr. Chopra, for that very lucid and very interesting presentation. Typically, when we have a primary on the table with an ST elevation and the patient having ongoing pain, and you find that there's an anomalous artery over there, which is the culprit vessel, it's always a situation when you know you're in a hurry to hook that vessel and go ahead. And that was a beautifully done case. So I just wanted to ask you one question is, do you consider that in cases like this, when we have an anomalous artery and we have sometimes a less than optimal hooking, and would you consider putting in a guide extension catheter inside the artery? Because that would increase the support, would also give you better visibility because you're actually injecting through the GEC, and would also give you support for the rest of the procedure. So would you do that?
Sure, absolutely. In this particular case, the problem was more regarding going deep inside the artery. And in that situation, definitely a guide extension catheter would have helped. So in case I had not been able to negotiate the hardware down, I would have done that. But actually, apart from the thrombosuction catheter, the balloons and the stents went in rather easily. So I didn't try to add the cost and the time involved in taking the guide extension. She had pretty severe pain, which started getting relieved once the vessel started opening. So I had a moderately stable position with the guide catheter. So I completed the procedure there. Of course, it's very well taken that in case there was any difficulty with taking the stent in, guide extension would have been the next logical step.
Great. I think we are well over time, so I'd like to thank Dr. Chopra and Dr. Sarita. Any closing comments from your side before we end the session?
So I would just like to say that it's been a very interesting morning. And I think all of the speakers have done justice to their topics. And it's been a very learning experience. And also the discussions have been great learnings. So in an acute MI situation, when the patient is sick, and we've seen the variety of scenarios which could happen, an anomalous, which is tough to deal at that point, a free wall rupture, which you're not expecting. And the kind of situations we've discussed, the use of imaging for optimizing, the use of when you suddenly see a patient with acute MI and the patient turns out to have multivessel, a huge thrombus burden, which was typically tackled with the penumbra. So there's still a place for thrombosuction in patients with acute MI. So I think it's been a very learning experience, great discussions, great presentations. And thank you so much, everybody. And we'll close for today. Thank you.
Thank you very much, and wish you a good rest of the day. And yeah, take care. Thanks. Bye.
Bye.